we get you back now. I'm going to kick off with 2 or 3 tables at a time in terms of posing some questions. Can I call on first maybe table number 2, 7 and 8, please? Table 2, please. Okay, we're back in session, please. Table number 2, if you want to pose, please. I can come back to you if you like, if you're not ready. Yeah, no problem. Table number 7, please.
Good afternoon to all of you on the top table. And firstly, congratulations, and the work that you do is incredible. One of the questions I have, and I suppose Eamon, you may be in a position better to answer it, and then I'll go and just look for you just to answer it very quickly, is if there was a national body, we've heard over the course of the last 2 assemblies about people not knowing where to go and get that facility when they need it. We've heard from different groups in the last assembly where they didn't know where to go. If there was a dedicated person utilising yourselves in the local communities then, but do you think there's merit for the assembly here to recommend one number that can be utilised in the 26 counties or the 32 counties, depending on, is there merit for that one organisation, and is there merit that everyone knows through advertising campaigns, etc., that can be utilised and then utilising? Because at the minute, there's so many wonderful organisations out there. Do you believe that would be a better idea?
Thank you. I'll go to table number 8 and then I'll be back to number 2.
Good morning to you all, and thanks again for your contributions. Pointing correct the question at John, but anybody probably could answer it. John, you mentioned that the Department of Taoiseach had previously set up this committee. Others have mentioned that it's a worthwhile exercise. Why did it fail? That's what we're looking to find out. Why did that not work? And by repeating it again, is it doomed to failure again? Thank you.
Very good question indeed. Table 2, I can come back again if you want. That's okay. You can add to it if you like.
Yeah, but just based on the recommendations, we wondered if this time it would be pushed through, because it was 15 years ago, which was quite progressive, I suppose, and it just maybe fell at the last hurdle. So yeah, that was our question too. Thank you.
No, really good question. So where to go? Is there a single point of entry into the system? And generally, if something failed, why did it fail? So we can know in our own thinking. So maybe Eamon first, please.
So in relation to the first question, there is a national helpline number, drugs and alcohol services, that people can access to, and we have that manned with counsellors who are trained Monday to Friday. We have out of hours email service associated with that, but I think it goes to the point that people don't necessarily know about it, So that service is there. They do have trained people able to talk to anybody, and if you send the email at the weekend, they'll get back to you early in the week. It's for drug and alcohol, so maybe we need one specifically for drugs and one separately for alcohol, but this is about drugs, and maybe we do need to look at what...
I think what the problem is that even people who were speaking on the last day here that were involved in drug services didn't know services that were available, and they didn't know where to go.
Yeah. Okay, well the helpline has...
People within the service organisations themselves. Okay.
The helpline is also only as good as the information that it gets in to it. So if you're phoning from, I'm going to say Galway, and the helpline aren't up to date in relation to the developments in Galway, then that's something that does have to be addressed. So we do also have a directory of services on drugs.ie that people can access and get information there about local contacts. But I think it goes back to the fact that it's not widely known, maybe not as widely known as it should be. In some areas it would be widely known, but
it's funny when you look at some of the organisations that spoke at the last assembly, people within those organisations didn't even know that these things were available, grant fundings were available. Where do they go? Where do people go if they have someone that they're worried about, someone that's suffering with drugs? And people within the organisations don't know that there's X, Y, and Z in it, how is the ordinary general public going to know it then?
Absolutely, and as I said, the helpline do take calls from family members. That's one of the big calls it takes. So.
Okay, can I maybe one of the other panelist members? This is an important one. Just saying.
Yeah,
John, and John, I'm going to come to you in a second as well.
Yeah.
Also in relation to the why some might fail,
Yeah.
but feel free to come in.
Yeah, just I don't know the context of the conversation that took place, but I ask anybody here, the whole lot is take out your phone and put drugs support services into your phone, and a whole load of stuff will come up. Particularly, and drugs.ie covers the whole country. The drugs helpline run by the HSE covers the whole country, and. But I think there's the element of your question that always crops up for me and the services I work with is that we do actually have to just constantly communicate with people out there, because with the drugs issue, it's only when it affects you you begin to think about where the support is, and if you're not affected, it's like one of those issues. I really don't want to know about it. It's really like a form of dissociation, and you're just like, I don't want to go there, I don't want to think about it for the general population, So, but like, even in terms of like our website, the Finglas Cabra Local Drug and Alcohol Task Force website that I work for, well, sometimes we get phone calls from people in Kerry, because for whatever reason, a whole load of phone numbers comes up, and we're the one that answered the phone at that particular time. Do you know what I mean? No, it shouldn't be. But I think the question is, I think the lesson or the message I'm taking from your question is that, look, we do need to put more into communicating what's available, because as I was saying earlier on, there's a myriad of stuff now. Now there is a postcode issue, as Breed said, in rural areas and outside of the big urban centres. But
Okay.
But the services are there, even during lockdown, when some of the services, say in Meath, were closed down, people were coming on the bus because they were hearing that services in Finglas were still open, and they were welcomed with open arms, because they were in difficulty, and they were able to find out that information, But I
Okay.
agree with you, but it's the
Thanks.
communication thing just needs to be constantly,
Thanks, John. I just want to keep us getting more questions here. I know somebody else wants to come in a minute, but can I just go to the second question there, which was around the issue of if a structure or an oversight or political oversight was put in place before, it seemed to dissipate, it seemed to fade away. Why? What happened? If you were to put something in place again, which Eamon has recommended, how would you make sure it has sustainability? So can I open that to the panel a bit? I know John said it, but to the panel overall, about this political oversight and Eamon as well, obviously. So anybody wants to come in first? Eamon, can I call you first, just on that one?
I suppose to a certain extent, because it worked. I suppose there were targets put at that time in relation to getting people onto opiate substitution treatment. Those targets were met. Then, as governments moved on, drugs weren't the same priority that they might have been at the time the task force was put in place, at the time of the Rabbit report. New governments came in. The Rabbit report happened at a time when drugs was the #1 issue on the doorstep. And I think we've got to remember that. Maybe drugs now is becoming a really important issue again, and maybe now we have to reinvigorate the approach that we're taking. So a cabinet committee where drugs are discussed and where all the government departments are able to put in their input about what are they doing in relation to making societal changes around drug use. I think that's what we need now. I'm not, the other one didn't fail, but it did go off the agenda because the targets were met. And as I said, and I've said before, we've got a lot of people into opiate substitution treatment, and in some ways we're not seeing young people anymore the same way. We're seeing young people with other drug-related problems presenting to us, and we have to respond to those. And maybe it needs the teeth of a government-led cabinet committee to do that.
And just before I go back to the floor, Tommy or Dermot, do you want to make any comment on this, or Breed?
Well, again, I think there is a significant question. Why did it fail, if that's the word that is being used? I remember some of the change that happened, structural changes in relation to how it was organised. So they probably had some element of influence on it. I think there are structural concerns. I think the second one is that sometimes when we get an answer, we believe we have the answer, and we forget that the question keeps changing. And so when I use the word agile about services, I think we need to keep, it's like, for example, the cocaine, crack cocaine, they're all very head shop drugs. The number of new presentations that have happened in the last 20 years are phenomenal. Ideally, we should have been responding in a very rapid way to those things in an agile way. We haven't. I think another piece that's now probably influencing this new change, which is really important, that's why this discussion is so important, is the role of recovery. So globally there's been a lot of work looking at that. What is drug use and what is drug use recovery? What's that mean? So again, there's presentations in relation to that. That's had a huge influence now, and also really putting in centre place the voice of people who've lived experience of drug use and the impact on themselves, their families and their communities. That's putting it very much back on the agenda. So in a way, it's a much better rationale for reviewing this. Before it was just like AIDS, the AIDS response in the 80s was. It's a stimulus response. It's always going to be reactionary and it'll have its difficulties, whereas this is much more organic and much more real and probably much more integrated and comprehensive. And again, it's coming from the ground, and this process again is a very much part of that. So
Okay,
hopefully it won't fail this time.
Thanks, Dermot, and a very clear message as well done. And Reid or Tommy, briefly.
I'll just pop in for a second. I guess it was a time of significant changes at government level. In '96 we had a rainbow, I think, a coalition government. Into '97 then Fianna Fáil got a majority. So different parties have different views on drug policy, etc. And I think the structures and services then expanded very quickly. So maybe people thought everything was generally okay and working well. But we must, and I'd say to you, recommend keep a minister for drugs and try and keep them at the cabinet table. That's very, very important. But I wouldn't say it failed, but I think it's maybe just down to party priorities and a significant change between '96, as I said, a coalition into a majority. That was probably the result of that.
Thanks. Sorry, I just want, because there's a few people on the floor who want to come in as well. I will, but Reid, quick comment, and I want to go back to the floor as well.
Yeah, I mean,
Go ahead.
I would say the same thing. There's been a lot of change, and the landscape did change, and the addiction services, I suppose, and our response was really focused on opiate use, and then as the different drugs, the drug landscape changed, we weren't responsive to it. And certainly, and we would see this certainly within the 24 task forces around the country, there was a lack of political will, and I think it's fair to say that it just fell off. Other things were happening. It was seen that this was working very well, and it just kind of disappeared off the landscape, and some of our statutory partners then stopped getting involved. So I think that this is an opportunity to mandate those statutory partners to once again come to the table and really engage in the process so that we can make real change.
Okay, I know there's no people from the floor and the panel want to come in again, but I'm really anxious to get the remaining tables who won't have asked. So there's 4 remaining tables between the last 2 sessions haven't. So tables 9, 3, 10 and 12. If you can get ready, please. Table 9, and then we can go back to some extra inputs. Table 9, please.
Hi, thank you to everyone. 3 questions from our table. To Breed Walsh is the first question. If all partners have an equal voice, how are decisions made? So is it consensus? Is it the majority? Is it the low-hanging fruit? How do you come to an agreement on how you spend your money? What's the reality of that, and does it take a long time to reach consensus? The second question, I suppose, is to Dermot King, and to congratulate him on what they've done there down in the south. And could we replicate that throughout the country? If the model works, should we not just be replicating that? And would that do away with the need for the voluntary organisations, in which case we wouldn't have this issue of disparity of pay and services? The second question is around the recommendation to refer this to the Department of the Taoiseach.
It's 3 questions, Ciara.
Yeah, 3 questions. Sorry, the third, the Cabinet Committee. So if a Cabinet Committee can be set up, it can be disbanded. And I think that's what Tommy and you've alluded to there, is that there needs to be political will. If we've learned anything from Portugal and Austria, it's that we need to depoliticise this agenda. And would it not be better off to take it out of government and to have a government, a joined up, coordinated approach? Thank you.
Thank you, Ciara, for breaking all rules. 3 questions put into 1. Well done.
Yes, we did as well.
Sorry, table 3, please.
Yes, I'd just like to say we're deeply impressed with what we've heard this morning from all of you, that so many voluntary bodies are doing so much for us.
Yeah.
A question for Eamon Keenan. With the evident rise in the use of opioids, a rise in cocaine, and a serious rise in cannabis, is this a mental health problem, or what is your opinion?
Okay, so thank you. Thank you for being very compliant. And one question. Table number 10, please.
Yeah. Hi, everybody. This is a question mainly for Professor Eamon Keenan, but everybody's thoughts would be appreciated. Just to use cannabis as an example, so how would the diversion programme deal with the 90% of recreational users who have no problems or issues? Surely pushing everybody into the health system would be a strain on an already very overburdened system. So I just wonder your thoughts on that, or how we might mitigate that. Thank you.
Thank you very much. Thank you. And table 12, finally. If I have missed a table, please let me know. But table 12.
Yes, hello. I have a question to all the service delivery partners. And as I understood that we all based on volunteers, and how do we recruit our volunteers? How do we train our volunteers and make sure they are well skilled to do the job? And how to engage their commitment? And are there any risks to leave like inexperienced volunteers to do the drug support jobs? And how long is the waiting times for someone to access every service that we talked about? Speaking of the the preventions, and the last question is, do we proactively reach out to people who need help, or we are just waiting for the helpline and the referrals? Thank you.
Thank you. Okay, so I'm going to go to people individually first, and then we'll open up where we can, but just to try and make sure we do justice to all the questions. The first one, Bree, just round if you can, and again, panellists, if you can, be nice and brief and sharp. We'll get through all of them and more. The issue around decision making and how does it work in practice at the Drugs and Alcohol Task Force?
Yeah, I suppose there's a whole process around that, and we look at lots of different evidence from experts. And when we say experts, we mean experts by experience. We mean experts who work in the treatment sector and have that knowledge in relation to interventions. We mean expertise in relation to research, what's been done, what's been proven to work. So in very practical terms, what that means, we also look at demographics, so are there areas where there are particular social determinants that would indicate that there would be likely to be drug issues there. And then from communities themselves, nobody knows more about what's happening in the community than the people who live there, and nobody knows more about drug use in the community than the people who use drugs there. So together we will sit around the table, and I'm going to be really practical here because I think that's what you're looking for. Yeah. So we will present all of that. We will present the data from the Health Research Board to show, look, this is what's happening in the area. We will get the experience from people on the ground within the community and who are using drugs. We've loads of mechanisms for that. We have an expert by experience network, for example. We do co-production groups where we would have professionals alongside people who are involved in services working together on what the needs are. It's not you go to a meeting and you just decide what you're going to do with the money. It's looking at all of those things, getting the feedback from the other services that there are in the area and what they're seeing, and then we present all of that, and it's based on that the decisions are made. Okay. And I can say there's very little contention. Usually after all of that, it's a very logical kind of approach to making a decision in relation to maybe focusing on a youth focusing on one particular area because that's what's indicated.
Thanks, Breed. Just conscious we can have discussions outside as well. I'm really just conscious. No, please do have a chat with Breed over lunch as well. I just want to get through them again, so panellists, please stick with me because we're eating into the deliberative time at the tables. Joe, quick one on the model in Cork Kerry, if it's integrated and working well. How can we replicate it? Why not? Etc. And you're in the health service, Joe. So, Joe?
Yeah, so look, obviously every part of what we do and part of what you're doing today is looking at models that can be scaled up, so absolutely there's potential to scale up any models that are working well. You mentioned the community voluntary sector within that as well, and I think something around the raising the community voluntary sector. So just for clarity, the partnership between the HSE and Coolmine, it doesn't work without Coolmine. It's the partnership approach that is working. They have the same issue with that pay parity piece. That's a reality for their staff as well. It's an issue for us in the HSE and our other funded. So that's still there. But absolutely, where we've come from in terms of our structures, very fragmented. And as I said, a patchwork quilt to what we have now is improvement. It can be done. It's a lot of hard work. And it requires significant partnership, and I mean that, to deliver integrated care. So it's, everything is scalable, absolutely.
Thanks, Joe. I'm going to go back to the Cabinet Committee issue and oversight, political oversight, because we gave a good discussion, but if I have time I will come back. The issue of mental health issue and its relationship with addiction, Eamon, can you take that one? And also the demands that may be on the health system with a health-led approach in terms of cannabis use from people who may not be receiving harm and rooted into a health-led approach. If you can just take those two, please.
Okay, well, the first one in relation to cocaine and cannabis and the mental health issue, I think I'm really strong that yes, they do contribute to mental health problems, and we've seen that if you look at our data around admissions to hospital for people with cannabis-related problems or cocaine-related problems. We had a difficulty with mental health in terms of Vision for Change, which was our strategy in 2006, which put addiction outside mental health. The most recent strategy, Sharing the Vision, in 2021, did get addiction problems recognised as having significant mental health connections. And that's where we now have the model of care that I spoke about in relation to dual diagnosis put in place in May of this year. But I first started talking about a model of care for dual diagnosis nearly 20 years ago, and it's taken till May the 23rd, and I remember the date because it was an important date, that model of care gets put in place so that people with coexisting substance use and mental health problems can get appropriate treatment. It needs to be resourced, it needs to be expanded. The second one then is in relation to the cannabis and the 90% of people who are presenting to the health services following a referral from the guards. Is that the cohort you're talking about? So similar to the Portuguese model, people who are caught in possession of drugs for personal use will be sent to the health service, dissuasion committee, same sort of thing. The vast majority of them will not need onward referral and treatment, but they may benefit from a brief intervention where somebody with training can speak to them about their drug use, highlight the risks and harms associated with the substance, and then tell them where services are if they ever need them. For that 10% or maybe 10 to 15% of people who need treatment, then we need to have referral pathways put in place into treatment services so that they can be responsive, and we need resources to be able to do that. So absolutely the health diversion programme is for everybody who's caught in possession of drugs. Not everybody will need onward referral for treatment, but everybody will benefit from a brief intervention.
Thanks, Simon, for being brief and very clear. Can I ask Dermot, just on the last question around recruitment, training and waiting times for access and retention indeed of staff just into the voluntary sector? Do you want to make some comments on that?
Yeah, just if I can specifically take up the question in relation to the volunteer piece. Yeah, the organisation that I'm part of, the Ballymena Youth Action Project, it started in 1981. The very first thing they did was, the group of volunteers who came together was, they said, we need to know what we're doing and we need to do training. So that is a core ethos within the community voluntary sector. And again, from quite early on, Caroline's over there, the Quality Matters developed in the community voluntary sector a whole series of standards for all of those different dimensions. So it's always been seen as a priority. Just very recently, the Addiction Council of Ireland, which is the body that regulates a lot of the addiction workers, they've introduced, there's a accredited status for project workers, and the supervision programme for that has just been set up at the moment. So there's a real emphasis on that, and there is training for community members, professionals who are involved in all that. That has become more and more available. But the difficulty is that the structure doesn't really prioritise that. So it's seen as an add-on. So rather than have proper education in relation to effective response as a core part of the overall strategy, it's an add-on. So again, I think it's a crucial point that, and it might be part of the reason why there's a difference between statutory and the voluntary, because there can be a perception out there that the voluntary are only voluntary people. They don't really know what they're doing. The fact that they're all so easily recruited into the statutory sector is because they're very good at what they do. They're very professional and very competent. So I think that's a piece. Does that make sense?
Okay, Tommy, very briefly,
Yes.
because we do need to go back to the tables now.
I'll just take the waiting time question and actively reaching out to people in the community. In JAD, there's no waiting list. I'll give you an example of Monday, somebody presenting for methadone treatment. The nurse assessed that individual or was available to assess that individual on the Wednesday in JAD. So there are no waiting lists in our service for opioid addiction or methadone or our psychosocial services. On actively reaching out, we have an assertive outreach team at the moment, as I said, funded under the crack cocaine budget, and the HSE also have an outreach team operating in the community. We have very good systems in place for picking up people. We have great relationships with service users who make us aware if there's new people in the community. It's a strong sector and we're actively on the ground engaged with people.
Okay, Tommy, and thanks for being clear on that one again. It's good to hear actually that in terms of accessibility and timeliness. Okay, I'm very conscious more panellists want to go in, more people from the floor want to go in. Can I just ask you, I think everybody will agree, we got the last Assembly meeting a good insight into some of the human experiences and the lived experiences, we called it. Today I think we got a good insight into some of the service delivery design of some of the that are doing some really good work and some good services and with some really good outcomes and some innovative thinking about what we might do in the future. So please show you a round of applause for the panellists. Thank you very much.